Hi, my name is Rosie Collier. As part of the assessment for the PBL5 module, I'll be presenting my understanding of CPD and how it will support both myself and the service I work in as I transition from a student to a newly qualified practitioner. In the first part of the presentation, I'll cover what CPD means, the expectations and standards we're expected to meet, how CPD positively impacts clinical effectiveness and service development, how my responsibilities around CPD will change once I'm qualified, and common and personal barriers to engaging in CPD. The second half will focus on a reflection on a SWOT analysis of my own development needs, and I'll set goals related to both service development and clinical effectiveness. What is CPD? CPD is about the ongoing commitment to growing and developing as a practitioner so we can deliver high quality care and contribute effectively to the services we work in. It benefits not only us but our service users and the organisations we're a part of. CPD has been introduced us throughout university because it's such a key part of our future careers. Both the CSP and the HCPC define CPD in similar ways. How we maintain and develop skills, knowledge, and competence to practice safely and effectively. The CSP, when talking about applying CPD in practice, state that when you graduate, you should be clinically competent, person-centred, and aware of how you will fit into the wider systems. But beyond that, you should also be ready to bring change to those systems, which means being able to step outside yourself and question both your practice and the system itself, which this presentation will guide me to do. To support ongoing development, we're expected to keep a record of our CPD. This is HCPC Standard 1. Your CPD record should be specific to your role in practice, a mix of formal and informal learning, reflective and evaluative and not just descriptive. If you're selected for audit, which happens every 2 years, you'll need to provide clear evidence of your learning activities that demonstrate this. The HCPC CPD standards set out what we're expected to do to stay current and reflective in our practice. These include keeping a continuous, up-to-date and accurate record, making sure CPD includes a mixture of learning, ensuring CPD benefits the service user, using CPD to improve the quality of practice and service delivery, and providing evidence of CPD if selected. To meet HCPC Standard 2, CPD should come from a mix of our 4 learning categories. The first is work-based learning, which includes reflecting on patient cases, involvement in service development, reviewing patient or service feedback, and learning through team interactions. The next is professional activity, which can include getting involved in a professional body, presenting at conferences, organising case-based learning sessions, and mentoring students or junior staff. The next is formal education, which includes attending HCPC-approved short courses, taking part in formal research, simulation and skills lab sessions, and accredited e-learning or university-led programmes or webinars. The last is self-directed learning, which includes critically appraising journal articles and listening to specialist podcasts. It also includes using apps for skills refreshers and setting and reviewing SMART learning goals. Along with the HCPC CPD standards, we need to meet the standards of proficiency within our scope of practice, the CSP Code of Members' Values and Behaviours, and the 4 pillars of practice: clinical practice, leadership, education, and research. These frameworks all work together to define what it means to be a safe, skilled, and professional physiotherapist. They help us stay focused on practicing ethically and with integrity, communicating and collaborating well, continuing to develop and reflect, and ultimately delivering the highest quality care we can. In relation to CPD, these standards can be used to guide and shape CPD activities. Linking CPD to these expectations ensures that development is meaningful, targeted, and also helps us to meet the requirements themselves. I have already outlined the overall role of CPD, but it's also important to understand how CPD specifically contributes to service development and clinical effectiveness. Clinical effectiveness is about delivering care that is evidence-based, tailored to individual needs, and proven to lead to better patient outcomes. It's essentially about doing the right thing for your patients every time. CPD supports clinical effectiveness by helping us stay updated on evidence-based practices, encouraging reflection on our experience to tailor future care, and ensuring continuous learning so our practice remains current and safe. The HCPC Standards 3 and 4 reinforce this by stating CPD must enhance the quality of practice and benefit the service user. Service development means making care safer, more efficient, more patient-focused, and involves learning from experiences, working collaboratively, and implementing positive changes. These changes may be formal, audits and research, or informal, adapting how a clinic is run. In 2008, the NHS paper High Quality of Care for All emphasised the importance of service improvement as part of an NHS reform. Since then, various initiatives have empowered staff to contribute to service development. CPD contributes to service development in two main ways. The first is service improvement activities are a form of CPD, and the second is CPD helps identify opportunities for service improvement. Again, HCPC Standards 3 and 4 state CPD should enhance service delivery for the benefit of service users. The CSP's 4 pillars of practice all directly link to clinical effectiveness in service development. Clinical practice supports clinical effectiveness by delivering evidence-based person-centred care and also allows us to spot service gaps in everyday work for development. The research pillar of practice encourages applying evidence for effectiveness and being involved in service improvement projects for research. The leadership pillar is not just about formal titles, it's about shaping a positive team culture where clinical effectiveness and innovation are encouraged. And lastly, the education pillar keeps us up to date and capable of making informed clinical decisions for clinical effectiveness while also contributing to workforce development and service enhancement. As I move from a fourth-year student to a newly qualified practitioner, my role will shift from placement-based learning to working independently within the team. This change comes with new expectations, especially around responsibilities for my CPD. The CSP Physio framework outlines how responsibilities develop over time, from being a student receiving advanced support to becoming a graduate who's more independent. For example, relating to maintaining the effectiveness, efficiency, and quality of practice. As a student, I'm expected to recognise and report situations where services may be compromised. As a newly qualified practitioner, I'm expected to take appropriate action on this with support, actively contributing to service development. This is reflected in most Band 5 job descriptions. In terms of the ongoing development of professional competence, as a student, I'm expected to advance my knowledge and skills in line with identified learning needs with support. As a newly qualified practitioner, I'm expected to do this independently, identifying learning needs using a range of CPT resources. The key shift is that while support is still available, I'm now fully responsible for driving my own development, seeking advice when needed, and ensuring I meet all regulatory requirements. Later in the presentation, when I share my CPD goals, I'll link them directly to what's expected of me within the Physio framework as I step into this new phase of my career. We've already looked at how CPD benefits clinical effectiveness and service development, which highlights some of the key drivers. As I transition into practice, it's useful for me to recognise both what helps and hinders my engagement with CPD. I've broken these down into internal factors influenced by myself and external, influenced by my environment. These are based on personal experience and what I found in the literature. Internal drivers include a strong desire to stay updated with current knowledge and maintain high standards of care. The awareness of how CPD directly impacts clinical effectiveness is also a driver. There's also the driver of willingness to learn from my mistakes, fear of lack of personal growth, and passion to progress my career. And also the awareness of the variety of CPD opportunities now drives me to engage. External drivers include CPD's role in driving service improvement, meeting patient and public expectations for safe evidence-based care, and the requirement to meet standards. Internal barriers include feeling awkward discussing personal learning needs with educators, confidence and time needed to identify relevant CPD opportunities, and difficulty maintaining motivation outside structured placement or academic settings. External barriers include limited time due to clinical pressures and understaffing, and reduced access to funding for courses. These drivers and barriers are not fixed. They will shift as I move from a student to a newly qualified practitioner and continue to change throughout my career. For example, the awkwardness of raising learning needs with my practice educator may now become the awkwardness of discussing it with my Band 5 supervisor. My motivation also may become more focused, like pursuing specific CPD that helps me specialise or move into a new role. And barriers like placement workload will likely shift to managing the full responsibility of caseloads. Now moving on to the second half of the presentation, I'll be doing an authentic critical reflection on my needs for personal development. This will help me identify clear goals for my CPD. Authentic critical reflection means being open and honest. It's important to reflect on all parts of an experience, including the difficult or uncomfortable areas, because that's where the real learning happens. To guide my reflection, I'm using Borton's model of reflection. It's a simple, structured approach based on 3 core questions: what, so what, and now what. I chose this model because it's clear, easy to apply, and pushes me to go beyond just describing an event. It helps me think about how an experience impacts my development and how I can improve my future practice. Although the model may seem brief compared to something like Gibbs, it still allows for depth by answering thoughtful questions in each section. The critical paper by Amade et al. Reviewed several models and highlighted Borton's as an ideal model for broader reflective thinking and not just tying your reflection to a single event. It does miss the feeling stages seen in other models, but this can be woven into the questions. Finally, this model aligns well with the CSP CPD cycle, which defines CPD excellence as reflecting, evaluating, and applying learning in a cyclical and critical way, which is what I aim to do. To lay out my personal and professional development needs for reflection, I'm going to use a SOAR analysis. SOAR stands for Strengths, Opportunities, Aspirations, and Results. It's a framework used to reflect, plan, and take action. It asks, what am I good at? What's available to help me grow? Where do I want to go? And what outcomes do I want to see? And how will I measure this? I chose SOAR instead of the traditional SWOT or SWOC because it's more strength-based and future-focused, which suits my personal development and reflection better. SWOC includes weaknesses and challenges, which can feel more problem focused. SOAR encourages positive values-based action, which fits well with the approach we take in healthcare. It helps me highlight what I can do well, where I want to grow, and what I'm aiming for. And it's known to help generate more innovation, motivation, and development planning. On this slide, I'm using the SOAR framework to analyse where I currently am. One of my biggest strengths is my ability to adapt communication. For example, I have used iPads to communicate with children with disabilities, simplified language for stroke patients, and explained conditions in a way that is understandable to patients and allows autonomy in decisions. This aligns with CSP value 3.3, communicating effectively. NHS Scotland value quality and teamwork, and I ensure this by gathering and using a wide range of evidence and sources such as patient communication, track, portal, and family to inform clinical decisions, aligning with CSP value 1.3, members make informed decisions. In terms of opportunities, I have a unique opportunity during my final placement to get involved in a programme and develop my quality improvement skills. Although I've had university education on this, I haven't had much hands-on experience yet. Another opportunity I've identified is the opportunity to improve how I reflect on my impact on my CPD. This is something I struggle with as I often undertake CPD without fully evaluating the impact, which means there's not a change to my practice. This aligns to HCPC standards 3 and 4. I aspire to be a therapist who constantly develops and continues to drive service development. I also aspire to fully achieve autonomous practice, especially when it comes to discharge planning and understanding resources available in the community to support safe and effective discharge. This supports HCPC Standard 4 to practice as an autonomous professional. To measure my progress, I can use CPD logs, feedback from supervisor, and reflect on my confidence in these areas using CPD reflections. I'll know I'm progressing when I can apply my learning, contribute to changes, and make decisions more independently and confidently. Now that I have laid out my SOAR analysis, I'm going to reflect on it using Borton's, along with the CSP CPD cycle. Looking at where I am right now. My CPD mainly focuses on formal education and self-directed clinical learning. Clear weaknesses include that I lack real-life experience and quality improvement, and my difficulties faced with discharge planning, allowing me to engage in the MDT. This became clear to me on previous placements when my educator was leading a self-management program in the stroke ward, and I didn't fully understand the process. The discharge planning is another area I feel unsure about, which when I recently read the paper Hospital Discharge Planning, a qualitative study of new grad physios experiences by Martin et al., I realised a lot of newly qualified physios feel the same. The weaknesses of work-based activity in my portfolio means I am not meeting CPD Standard 2, that learning should be a mix of activities. So what? These gaps are affecting my confidence as I get ready to qualify. I want to be the kind of therapist who leads or contributes meaningfully to improvements in services and identifies needs for this. I also want to practice more autonomously and will not have a supervisor to guide me in practice. Without better knowledge of community resources and discharge planning, I can't fully support patients beyond the hospital setting and contribute in the MDT. So I'm setting 2 goals for my final placement to address these areas. These actions will help close the gap between where I am now and where I want to be, and they also link to the planning and acting phases of Borton's model and the CSP-CPD cycle. As stated, Borton's and the CSP-CPD cycle end with a planning stage, highlighting that reflection alone isn't enough, and effective CPD requires action, and that starts with setting meaningful goals. As a newly qualified physiotherapist, I'm expected to reflect on my learning and use that reflection to plan and manage future development, which is what these goals aim to do. To structure these goals, I'm using the SMART framework, which the CSP, CPD, and Action recommends. It states that with SMART goals, just like the ones we use with patients, are equally powerful when applied to your own development. SMART stands for specific, measurable, achievable, relevant, and time-bound. SMART goals provide structure and help reduce stress by giving you a clear, manageable pathway. An article on setting SMART goals for student midwives explains that by planning effectively, you use your time more efficiently, reduce stress, and improve your chances of success. My clinical effectiveness goal is to improve my knowledge of discharge pathways and community resources within 4 weeks. This goal supports my sore aspiration of becoming a more autonomous practitioner and contributing effectively to MDT collaboration by developing a stronger understanding of this area. This benefits the service user by reducing long hospital stays, promoting timely rehab in the community, and enabling better outcomes at home. The service is benefited by supporting appropriate discharge planning, hopefully freeing up hospital beds and enhancing my team input during MDT discussions. To achieve this goal, I will ask my educator to attend a planned date of discharge meeting with me in the first week. I'll communicate with teams like occupational therapy, social work and nursing about discharge plans, and I will also request 30 minutes to review local discharge services and community teams with my educator. I'll review the Physiotherapy Lanarkshire Physio Services Available page on the NHS website. To ensure this goal is measurable, I'll track my engagement through halfway feedback, I'll complete discharge referrals, and I'll attend PDD meetings on my own. I'll reflect on my confidence in discharge planning using written reflections. This goal is achievable as it's appropriate to my current level as a final year student and new graduate, and I'll seek support from my educator and team. I understand that complex cases will still require supervision, which is part of safe practice. Being able to lead on discharge planning is a key expectation for newly qualified staff and relates to the physiotherapy framework of new grads. This knowledge will directly support safe, effective and person-centred care, fulfilling that responsibility to work effectively with others to meet the responsibility of professional practice. I've set a timeframe of 4 weeks, which is a realistic period to learn the available community resources within Lanarkshire and how to use them appropriately. Some potential barriers include awkwardness in discussing my learning needs with my educator and time constraints, so I need to confidently and clearly raise this goal with my practice educator so time can be allocated. Finally, this goal has long-term value. As I move through different health boards and rotations, understanding discharge services and knowing how to liaise with external teams will remain an essential skill. It aligns with NHS Lanarkshire's objectives of improving access, outcomes and patient experiences to deliver resilient and sustainable care. My service development goal is to undertake a quality improvement project to identify a new physical activity subjective outcome measure for cardiac rehab patients within 6 weeks. This aligns with my SOAR opportunity of building confidence and quality improvement, contributing to the work-based learning CPD category. The project incorporates feedback from service users who have expressed that the current outcome measure doesn't reflect their progress and is difficult to understand, which highlights the need for a more acceptable tool. This benefits the service and the service users. Service users will benefit from a more meaningful measure of their progress, making their rehab journey feel clearer and more motivating. The service benefits by being able to better demonstrate the impact and effectiveness to stakeholders, supporting ongoing funding and service development. With the support of staff and a linked university project tutor, I will review relevant literature on physical activity outcome measures, assess the feasibility of outcome measures in cardiac rehab patients, and plan how a suitable measure could be implemented. Independently, I will read NHS England's First Steps Towards Quality Improvement, aiming to complete chapters 1 to 10 during placement and chapters 11 to 13 as I move into practice. I'll also engage with resources such as PowerPoint and questionnaire design. I will present my findings and project outline to colleagues and my supervisor. I'll trial the new outcome measure and with selected service users and collect initial feedback and data, allowing me to measure my work. It is achievable as I will have support from the team and dedicated project time each Friday. While full implementation may not be realistic, the team has confirmed they'll continue this after I leave. It's relevant. As a newly qualified physio, I am expected to contribute to service development. According to the framework, entry-level grads should, with guidance, critically evaluate practice share findings and use problem solving to propose improvements. The 6-week placement is a clear timeframe. I will discuss with the team what realistic milestone looks like for handover by the end of placement. Identify barriers include competing clinical demands and understaffing and maintaining motivation. To overcome these, I'll set short goals and regular time slots during the week to update the team to stay on track, and I'll structure my Fridays correctly. Although this project is tied to my placement, it will directly support my confidence and quality improvement as I graduate. To build on this, I plan to complete the free accredited CPD course, Quality Improvement in Healthcare, The Case for Change, by the University of Bath, which is a 6-week online course at 3 hours per week within the 6 months of first 6 months of qualified practice. What I have learned. I have learned that that discharge planning is a common challenge for Band 5s and collaborative goal setting with OTs is helpful. I have achieved my goals set for placement and I feel more confident going into graduate practice. Understanding community service wait times and linking with the MS key team supports better referrals, which is something else I've learned. Resources for patients need to be clearly written and assessed for readability when conducting service improvement. A useful tool is the Gunning Fog Index. And acceptability questionnaires, such as the one developed by Secon et al., are useful for evaluating resources and interventions. I've also learned the importance of good documentation storage and information organisation when completing service improvements. And mostly I've learned you just need to do the best you can. CPD doesn't have to be perfect, but it's just little steps to help you improve. Thank you for listening.